We will be using this interview for a research and report published by Clarivate and our affiliated companies, and we will list you as a physician who has been interviewed, and we may publish quotes from this interview in our research, but we will not attribute any quotes to you. Is this clear and okay with you?
Yes.
Great. And before we begin, I must ask you to confirm a few more items. Please confirm that your participation is not prohibited or restricted by any employment, professional or legal obligation, and that you have obtained any necessary approvals from your institution to participate.
Of course.
Great. And also, it is not our intent to elicit any confidential information. Please confirm that you will not provide us with any confidential or proprietary information that belongs to your employer or any other third party or relates to clinical trials.
Correct.
Great. So thank you. So I think we can begin with our consultation. So we have 45 minutes, and how I would like to utilize this time. Obviously, first we'll discuss about the current standard care, standard care of treatment, which is followed for different set of hemophilia A patient, and then moving to unmet needs, and finally to the emerging therapies. Hope that's okay with you.
Yeah, sounds good.
Great. So let's start with non-inhibitor population. So my first question is how you manage this non-inhibitor patient. What's the standard care of or standard treatment that you offer to this patient? And now firstly about PUP patients, the patient under which are not treated, the new patients.
Well, in terms of clotting factor, we usually prior authorize all clotting factors, right? So the PA is pretty much the label. So if you're getting anything, you said hemophilia A, right? So there's several. There's the plasma derived. There's the extended half-life. So usually the recombinant, right? So we have PA criteria that first starts off with diagnosis of hemophilia, and then, we do the prophylaxis or perioperative or the treatment of bleeding disorders. I mean, usually that's why you're requesting a high-cost drug. And then generally we cover other drugs to label indication. We cover all of them pretty much. So Advate and Newick and Recombinate. So we've started to do more around hemophilia because it's for a very small number of patients where it's in the top 10 in terms of usually medical spend. But at this point we're not restricting. It's pretty much prior auth to label. We're not saying we have preferred agents and non-preferred products. They're all expensive. And so there's a PA. We do case management. We're requiring, usually, more around transparency around what gets ordered versus what's getting dispensed, especially if, specialty pharmacies involved. Doses on hand, which gets at trying to reduce waste. But the whole objective is to reduce bleeds, right? Reduce ER visits. The big thing now actually in hemophilia is we know gene therapy is coming. And so we're already anticipating what kind of, trying to forecast, what % of patients may qualify for gene therapy. Not everybody will. And patients who have inhibitors will not qualify for, at least in the first wave, for gene therapy. And it'll probably start with hemophilia B and not A. So that's even a smaller patient population.
Correct. So, gene therapy, let's park it, for now. Definitely I need to discuss that, but, we'll discuss at last. So, talking about, the treatment for hemophilia A patient, and I'm talking about a non-inhibitor population, first. And obviously, the Hemlibra, drug came into market and it's there from last 2 years. So how that changed overall treatment dynamics?
I think favorably, but as I've stated, we're covering all drugs, to their label indication. and leaving it up to essentially treating providers and patients. A lot of these patients, there's a lot of advocacy and patients want what they want. So many times it's actually them that are influencing the prescriber. But we cover to label and to label indication.
Okay, correct. Now in a non-innovative population, obviously we have severe, mild, moderate. So like the patient that you treat or in your treatment facility, if you need to give percentage in that, like how would be that percentage split between severe, mild, and moderate?
What percent of our hemophiliacs are mild, moderate, and severe?
Correct.
Oh. I don't know if we know that, right? I mean, we know those on factor, or the bleed, but you could be mild and bleed, or there could be trauma. So I don't know if we have that clear separation of, oh, these are the mild, these are the moderate, these are the severe. I don't think we know that. In general, we know the ones that are on factor. But I don't think it's broken out nicely as you want to. I think you're giving us too much credit.
Okay, no issues. So now, as you said that, yes, there are patients which are on factor. So do you think the patient gets shifted from factor therapy to Hemlibra? And if yes, what are such cases? And what percentage of patients actually get shifted from factor to Hemlibra?
Yeah, I mean, we saw actually some pent-up demand for Hemlibra, given, again, frequency of it just, it's favored by, some patients because it's just easier. But it's not like we're, for Hemlibra, I mean, our criteria are pretty straightforward, right? So a routine prophy to prevent reduced bleeds, and you have to have, mild disease and insufficient response to desmopressin, or why you can't use desmopressin, or moderate severe disease. That's pretty much it. So we are leaving it up to treating providers and patients to make that decision. It's not like we're forcing the switch.
Mm-hmm. Okay. And like, do you find specifically about Hemlibra? I know it sometimes it get difficult to measure a factor rate level. So do you think that adds a negative point for Hemlibra? With factor rate, definitely you can measure like what percentage of factor 8 is there in patient blood, but with Hemlibra it's not possible. So do you think that is a factor, could be a factor which is restricting its usage?
Well, we're not restricting it very much, right? It's for hemophilia A and the criteria that I listed. So routine prophy, to reduce bleeds, or you have, all the other indications that I mentioned, but that's pretty much it. So that, it almost seems like you think we're restricting Hemlibra. There's, the price is lower than a lot of the other factor replacements. So there's not a lot of reason to, be very restrictive.
Mm-hmm. Okay. And what's about patient with inhibitors? So how do you manage those patients?
So again, pretty much, like I said, we're not doing a lot in terms of restricting use of products beyond their label. So again, we're managing pretty much the indication.
Mm-hmm. But still, it's ITI is a first.
Yeah, so we have 7 fact, right? So recombinant. We have PA criteria around that, which is, 12 and older. If you have hemophilia A with inhibitors or B with inhibitors. But again, each, as products come to market, generally covered to their label indication.
Okay. Mm-hmm. And so I can understand, like with ITI. So definitely Hemlibra came as a wonder drug specifically for inhibitor population, and the patient who were not managed with factor VIII concentrate, Hemlibra actually came pretty good for them. But if the non-inhibitor patient, inhibitor patient, and they are still getting managed well with factor VIII,